all about the dry eye dilemma, past, present, and our future. So a little bit about me. My name is Kendall Montree, and currently I'm a senior at Magna Vista High School. In the fall, I plan on attending Radford University Carilion, and for my future job, I want to be a nurse practitioner in neurosurgery. A little bit of why I chose this topic. Prevalence of dry eye disease becomes because a common and often under-recognized condition that significantly impacts visual function and quality of life. Connection between the eye and the brain. The ocular surface and the tear film are closely linked to the nervous system, highlighting pathways relevant to neurology and sensory processing. Alignment with future career goals. Interest in understanding how ocular surface conditions relate to neurological function and patient perception supporting a future focus in neurology. Each one of us is at risk of developing dry eyes. We're not going to bed like we used to years ago, and we're not getting the amount of quality of sleep like we used to. All this plays into a development of symptomatic dry eye. Dry eye disease and daily function affects visual clarity, comfort, and overall quality of life. Increased screen time affects modern lifestyle changes, contribute to prolonged digital device use, which this is a huge key risk factor in this. Blinking patterns, reduced blink rate, and incomplete blinking. Not just how often we blink, but how completely we blink has become increasingly important, especially with extended screen time, for example, in the youth gaming. This can impair tear film stability, and this contributes to dysfunction of the meibomian glands that are responsible for stabilizing the tear film. There are a surprising number of patients who sleep with their eyes open, which is significantly symptomatic to the patient when they first wake up. Environmental factors, such as low humidity, air conditioning, wind and lifestyle, and prolonged indoor exposure worsens the symptoms. Contact lens wear and overwear. This can disrupt tear film and increase dryness. People tend to abuse contact lenses. Medications and systemic factors. Certain medications may reduce tear production or affect ocular surface health. Medications that can cause dry eyes include allergy meds, antidepressants, and some dermatologic medications specifically used for acne. Diet and nutrition. Nutritional factors, for example, omega-3 intake, may influence tear film quality. About 50 years ago, dry eye was mainly thought of as simply not producing enough tears, often linked to aging, hormones, and lifestyle. Now we recognize the dry eye, sometimes called evaporative dry eye, and this is having an adequate quantity or amount of tears, but that the tear quality and tear stability is the problem in this. The lipid layer dysfunction leads to tear film instability and ultimately contributes to ocular surface disease through efficiencies in both the quality and quantity of the lipid layer. These glands eventually weaken and lead to inflammation and sometimes a style or chalazion, in addition to changing the shape of the eyelid margin. Think of it like this. It's like having a windshield wiper that needs to be changed. Dry eye disease can be managed through a range of treatment options depending on the severity and underlying cause of this. We often start with over-the-counter artificial tears, which help to supplement the tear film and provide symptom relief for the eye. For patients with more persistent and moderate to severe disease, prescription medications may be used to address underlying inflammation and improve tear production. There are also procedural interventions such as punctal plugs, which help to retain tears on the ocular surface, and thermal pulsation therapies like LipoPlug. This targets meibomian gland dysfunction and opens up the gland during pulsation, massages, and improves the quality of the tear film. In addition to the medical and procedural treatments, lifestyle modifications play an increasingly important role in this. Research shows that simple changes such as taking regular breaks during prolonged screen time can significantly reduce dry eye symptoms. With the increase in digital device use, may be unaware that there are tools like smartphone applications can now prompt users to take blinking and screen breaks. This helps to reduce strain and support a healthier tear film function over time. Overall, management of dry eye disease is often complex with this, combining therapies to both relieve symptom and also address the root cause. Dry eye disease is evaluated through multiple tests that assess tear production, tear film quality, and the health of the ocular surface. This includes a patient history, a slit lamp exam, Schirmer test, which is what I use for my experiment, and tear breakup time. Other common diagnostic tests include ocular surface staining with dyes, like fluorescein, tear osmolarity tests, and advanced imaging of the meibomian glands. There are newer and better tests. Although we now have more advanced testing options than the Schirmer test, it is still widely used, especially in FDA-regulated studies for consistency. The ocular surface areas are also evaluated using vitamin dyes, typically glycerin green and a pinky rose mingle, to highlight the areas of damage to the cornea. A doctor will discuss with you your symptoms and use a slit lamp or any other test and examine your eyes for signs of dryness or inflammation. This takes me to my research question. I asked, does Schirmer strip testing of artificial tear formulations correlate with existing clinical practices? For my null hypothesis, the mean time for system was the mean time for refresh. For my alternative hypothesis, the mean times between cystine and refresh are different. For my independent variables, which is what you change, I have type of tear solution, volume applied, and my viscosity level. For my dependent variables, which is what you measure, I have the length of wetting on the Schirmer strip, which is millimeters, and time to reach certain length, which I use 10 millimeters and 5 millimeters on the Schirmer strip, and the total absorption at 5 minutes, which I did this experiment at 5 minutes. And for my control variables, I did sponge size, temperature, and viscosity level. Here's a visual representation of my experiment. So how I did this experiment was I got a cellulose sponge, which represents the dry eye in this case, and I got two different artificial tears, refresh and cystine, and I got Schirmer strips. So how I did this was on the sponge, I put artificial tear on it, and I held the Schirmer strip up to that sponge. And I conducted this at 5 minutes to see how long it would take to get to 5 millimeters and then 10 millimeters. And I did this at 5 minutes. And I did this 15 times per artificial tear. Here is my data analysis. So on the left side, it shows the time conducted at 5 millimeters. And the green shows cystine, and the purple shows refresh. And on that graph, it shows that cystine lasted significantly longer. On the right side, it shows the time conducted at 10 millimeters. And this one also shows that cystine lasted significantly longer on this one as well. The higher the millimeter means that it is faster and better for immediate acute relief or severe dryness. Slower millimeter is better for sustained, long-lasting hydration. For the rate of absorption, it measures speed. The total absorption measures the amount of moisture. For my results, the left side shows my testing for the 5 millimeters. The right side shows the testing for the 10 millimeters. So for my test, I conducted two different two-sample t-tests on this, and the alpha level I used was 0.05. So for the 5 millimeters, my t-test was a 4.71. My degrees of freedom was a 20.95, and my p-value came out to be at 0.00012. For the 10 millimeters, my t-test was a 9.51. My degrees of freedom was a 14.46, and my p-value came out to pretty much equal 0. The results indicate that there is statistically significant evidence that the mean duration time for cystine and refresh are different. Cystine lasts significantly longer than refresh on average. It is important to point out that we can't directly conclude absorption rates from this data since this wasn't tested on actual patients and human beings. We are not capturing how different tear film layers would affect absorption in a real clinical setting. We reject the null hypothesis because this is a significant difference between the two tear substitutes. The results indicate that based on the sample means, Cysteine lasts significantly longer than refresh on average. Dry eye years ago was approached as a purely symptom-driven condition. Doctors relied heavily on what the patients reported, such as burning, grittiness, irritation, and fluctuating vision. The assumption was straightforward: more symptoms meant more severe disease. Research has fundamentally changed that understanding. Today, we understand and recognize that dry eye disease is a highly complex and often mismatched. Patients can have severe symptoms with minimal clinical signs or significant ocular surgery with few complaints. It is important to understand that this disconnect highlights the subjective nature of dry eye that is influenced by variability. Anterior film stability. Differences in the corneal nerve sensitivity and the role of inflammation in neurosensory pathways. This shift has transformed clinical practice, and we no longer rely on symptoms alone. Objective testing such as the Schirmer test and other testing is essential. Treatments are increasingly personalized, targeting this underlying cause, not just symptom relief. The key takeaway is dry eye, not just what the patient feels and not just what we see in this. It requires both patient experience and objective data to truly understand and treat this. Moving forward for our future, the goal isn't just to relieve symptoms, but to identify the specific drivers of this disease, and each patient and tailor therapy accordingly. Over the past 2 decades, the definition of dry eye has evolved significantly. Initially, it was described as a tear film disorder caused by either decreased tear production or increased evaporation, primarily focused on symptoms and the surface damage of the cornea. The TFOS DUCE 2 report later reclassified dry eye as a multifactorial disease, introducing key concepts like inflammation and tear film hyperosmolarity. More recently, this report definition emphasizes a loss of tear film homeostasis and includes additional factors such as neurosensory abnormalities, helping explain the mismatch often seen between clinical signs and patient symptoms. Overall, these updates reflect a shift from a simple tear deficiency to a more complex multifactorial disease process. For my limitations, my first limitation was tear production assessment through the Schirmer test only without any additional testing. My second limitation was actual patients in a clinical setting. It was very hard with this experiment to compare an actual patient to a cellular sponge, so that was a huge limitation in my experiment. And my last experiment was viscosity as the only independent variable. A special thank you to my mom for her guidance and support. Her knowledge of the eye and the dry eye disease helped me better understand how the eye functions and what dry eye disease involves. I would like to sincerely thank Dr. Alan Carlson for his mentorship and guidance. His expertise in the cornea and the dry eye was essential in deepening my understanding beyond the basics, along with the time he generously devoted despite the many clinical and personal schedule. He was instrumental in expanding my understanding and supporting my research project. Thank you to the judges and the audience for taking the time to hear my presentation. This project has been personally meaningful to me in many ways, and I'm grateful for the opportunity to share it with you all. Questions?
Good job. Alright, so I was just curious why those particular brands, Sistine and Refresh. I don't know if there's others, but like why those particular brands did you pick for your research?
Good question. So I did a lot of talking with my mom and especially Dr. Carlson, and these two, it was very hard to pick because there were so many, but these two were the top two that were recommended for patients to give better relief for the patient. And also Refresh is better because it lasts longer in your eye to help with relief of the eye, and you want it to last longer. Systane is still good, but Refresh is better.
You may have mentioned this already, but why did you choose the sponge, the cellulose pad versus like something else?
Okay. So the cellulose sponge, It pretty much represented my dry eye. Like, it was like the closest thing to represent dry eye, because nothing else really helped with that, so that was the best option to use from my experience, to kind of use that instead of an actual patient. So, thank you.
Thank you, Kendall.